Welcome back. This is part 2 of the cardiovascular lecture. This section explains how your sympathetic nervous system and the parasympathetic nervous system work together as foils, or yin and yang, balancing each other out. Their key anatomical differences, where the nerve fibers originate and where their ganglia are located, drive their distinct anatomical functions, making your sympathetic nervous system the fight or flight, while your parasympathetic nervous system is for resting and digesting. And you can see by this model that the parasympathetic, one of the main ganglia or nerves, is the vagus nerve, and its main neurotransmitter is the secretion of acetylcholine. And in the heart, there are the cholinergic receptors. In this particular case, with acetylcholine as the neurotransmitter, we know that the receptor is of the muscarinic type. Now, on the other hand, the sympathetic nervous system, for example, the thoracic spinal nerves, will secrete norepinephrine at their preganglionic synapse, their postganglionic synapse, and they will stimulate the beta-1 noradrenergic receptors of the heart, for example. And you can see that this beta-1 adrenergic receptor is both present at the atria and the ventricle to stimulate the heart to increase heart rate, for example. Epinephrine is another neurotransmitter that is related to norepinephrine. And for the context of this talk, we'll consider the function of norepinephrine and epinephrine similar. And as you can see also that the sympathetic is considered the accelerator of our entire body, our entire organ system, whereas the parasympathetic acts as the brake. So sometimes you'll hear the terms their sympathetic tone or parasympathetic tone. That just signifies that both of these are almost always at play in one another to balance the functions of our body. What is the autonomic nervous system's impact on the heart? So again, it's going to be twofold, as you can imagine. On one hand, the parasympathetic nervous system applies the brake through acetylcholine. It will lower your heart rate at rest from 100 to 70 beats per minute on average via the SA node. The parasympathetic obviously will then decrease heart rate, HR, and it can also decrease the contraction strength and therefore decrease stroke volume. Thus, one way to look at this mechanism as well, as I mentioned about the tonality of this autonomic nervous system, heart rate and stroke volume, you can increase it by decreasing parasympathetic nervous activity. Okay. On the other hand, the sympathetic nervous system, it innervates the entire, it can innervate the entire heart, including the SA and AV node and the entire myocardium of the atria and ventricles. And that's not necessarily the same as parasympathetic stimulation of the myocardium, where it's mainly above the ventricles. So the bottom line is the sympathetic nervous system, it accelerates the heart via the norepinephrine-epinephrine system. And again, we won't make a distinction between these two, and their action we'll consider them as one. Its main function is to increase the heart rate and increase contraction strength, so therefore increasing stroke volume. Therefore, heart rate and stroke volume can increase due to increased sympathetic nervous activity. So how does this work? Let's take a look. So let's look at the mechanism for modulating depolarization for all heart cells. And we know that the receptors of the heart, whether it's adrenergic receptors or cholinergic receptors, mentioned in the previous slide, are G protein linked receptors that alter the permeability of sodium channels, which obviously impacts its depolarization. So how do we control action potentials? There's going to be two ways. In the heart, we have the two different cell types in the heart. We have the pacemaker conducting cells, and we have the contracting cells. So we know that there's only 1% of pacemaker cells, but that's all you need for them to do their job. As far as what is the parasympathetic's impact on heart rate, its main thing is to slow the heart rate down, as well as compare that to the sympathetic nervous system. It's going to increase the heart rate. So our fight or flight, okay, versus our rest and digest. And then, excuse me, the contracting cells, it's going to be the same, but the impact on stroke volume by altering the strength of the ventricular contraction. Okay, so that just tells you whatever is happening to the pacemaker cells, it's going to be happening also to the contracting cells by altering the strength of the contraction. So if you look at the action potential here in graph figure 12.2, the action potential over time, we have three action potentials. One, shown here in A, is the control. So let's consider that maybe a normal tonal level of activity. And then when there is a sympathetic stimulation, so when you are in the fight or flight mode, when heart rate increases and blood flow increases, it would be this action potential in B, where the difference is showing you as far as time, it's a shorter duration, making heart rate more frequent and increasing the heart rate. And then you can compare that to parasympathetic stimulation, where the onset of the action potential for everyone is the same, but it is elongated to slow down the heart, for example. And here, as mentioned in the part 1 slides, the conducting cells, or the pacemaker cells, you have these sodium F-type channels that are funny or leaky. You have calcium T-type that are transient or boosters channels. You have calcium L-type channels, as well as the potassium channels, where the potassium is open and sodium closes for repolarization to occur. And this would just show you just the contracting cells, or your normal everyday 99% of all myocytes, myocardium cells are composed of this type, where you have the normal sodium channel, calcium L-type channels, as well as potassium channels. So the autonomic nervous system is responsible for modulating heart and vascular function. We also want to highlight the importance of controlling peripheral vascular functioning, as we'll allude to that more in detail in the upcoming slides. So do you remember what neurotransmitters are released for muscle from the postganglionic ANS neurons? Well, you should know that. The neurons are cholinergic. That is, the acetylcholine is the primary neurotransmitter. And we know that nicotine as well as acetylcholine are two neurotransmitters that can act as cholinergics. And they can act at the level of the muscarinic receptors, here shown here on the right side, muscarinic receptors. Okay. There are also nicotinic acetylcholine receptors in the ganglion, at the parasympathetic ganglion here, shown here, these guys. Okay, in the sympathetic division, if you look at the sympathetic division now, neurons are mostly adrenergic, that is epinephrine and norepinephrine, and they're the main neurotransmitters. So here are your norepinephrine neurotransmitters, and here are your epinephrine neurotransmitters. Okay, and they can act on smooth or cardiac muscle glands or GI neurons. Acetylcholine, norepinephrine, and epinephrine. This is showing just a control of the autonomic nervous system, a summary of the highway or the map, if you will, of how the ganglion or nerves of the parasympathetic and the sympathetic division stimulate their endpoint, that being smooth muscle or cardiac muscles, glands, or other neurons in the GI, for example. So just note that the acetylcholine is the neurotransmitter here responsible for parasympathetic innervation, both at the ganglion level, as the communication is being bridged, as well as at the site of the receptor level, with the muscarinic receptor here being stimulated by acetylcholine. On the other hand, sympathetic division, the nerves of the sympathetic, like for example, your thoracic nerve, can release norepinephrine and be received by adrenergic receptors here at the smooth or cardiac muscle tissue, as well as epinephrine can be in your bloodstream, that can be released by the adrenal medulla, excuse me. So notice that acetylcholine, interestingly enough, can be released at the sympathetic level, and the ganglion can go ahead and stimulate the adrenal medulla to release epinephrine into the vasculature. Some pathophysiologies associated with autonomic nervous system neuropathy, for example, can include issues with regulating blood pressure, temperature control, digestion, and bladder function. Interestingly enough, diabetes sometimes is generally the most common cause of autonomic neuropathy, and even infection can be to blame as well. Some medications may also cause nerve damage, and symptoms and treatment will vary based on which nerves are damaged. So let's look at the control of blood vessels. And we know that at the level of the arterioles, that there is no parasympathetic innervation, but instead it's sympathetic. There are both alpha-1 adrenergic receptors as well as beta-2 adrenergic receptors. So both norepinephrine and high levels of epinephrine causes vasoconstriction, and i.e., for example, both norepinephrine and epi both activate alpha-1 adrenergic receptor. Okay? And the diagram here shows what that arterial diameter is controlled by the tonic release of norepinephrine. And during normal tonic release, where the electrical signals are at a normal release, there are moderate signal rate results in blood vessel of intermediate diameter. So intermediate, let's just consider this normal. So we see that there is this normal diameter of the arterioles. And so what happens when we change a signal? What happens when we increase norepinephrine? Well, when you increase norepinephrine, the signal rate will increase. Notice that the frequency here has increased considerably, thereby constricting the arteriole. So notice the constriction or the narrowing. On the other hand, when we decrease norepinephrine release onto the adrenergic receptors, so that the signal rate decreases, the blood vessel will dilate. So notice the opening of the arterioles. So let's look at what's happening to the skeletal muscle arterioles during sympathetic nervous system stimulation or fight or flight. We know that the alpha-1 adrenergic response is going to be to constrict blood vessels, arterioles in this case. But it's different with the lungs. In the lungs, there are isolated beta-2 adrenergic responses that dilate. So understand this rule, ACBD, and not ACDC, meaning that the adrenergic constricts and that beta-2 will dilate. And we know within this context of the lungs that there are low levels of epinephrine, or there are no alpha-1 receptors in the lungs. Let's look at the skeletal muscle. What do we generally want for fight or flight? Well, generally, especially in our muscles, we want an increased blood flow in our muscles to get our muscles moving and running. However, we also want decreased blood flow in certain areas of our body. For example, our GI tract, we want decreased blood flow in that area. In general, we know that the levels of epinephrine are going to be high. And let's look at what we've talked about in general so far. The general rule of vasoconstriction with norepinephrine and epinephrine. Is it wrong? Yes and no, and it depends. So let's remember that in most arterioles that the alpha-1 outnumber beta-2. So then therefore we know that the main effect of epinephrine is vasoconstriction, just like we saw in previous slides, with the exception of the heart, lungs, and skeletal muscle. So generally, norepinephrine and epinephrine are vasoconstrictive, acting on alpha-1 adrenergic receptors. However, the arterioles of skeletal muscle, cardiac muscle, and pulmonary circulation vasodilate in response to these hormones when they act on beta adrenergic receptors. And that's what you see here as kind of this final outcome in this model, in this diagram, that both the release of norepinephrine and the release of plasma epinephrine can both cause vasoconstriction if it stimulates alpha adrenergic receptor, but it can cause vasodilation if it stimulates beta-2 adrenergic receptors in heart, lungs, and skeletal muscle. Okay, so again, it's this idea of balancing the tone that's needed, and that the accelerator of our system, the sympathetic, is always counteracted by the brakes of, for example, the parasympathetic. Let's look at further physiological effects of the autonomic nervous response and look at, as a whole, the sympathetic and the parasympathetic receptors. So if we look at the end organs, so if we look at the lungs, we know that the lungs in the bronchioles, we want the bronchial to either dilate or constrict, right? To either respond in terms of needed air flow or restricting airflow. So as far as kind of increasing airflow, we want to activate beta 2. With respect to decreasing airflow, we want to stimulate muscarinic receptors of the M3 variety. In the heart, we want to stimulate beta 1 adrenergic. If we want to decrease the heart rate, we want to stimulate M3 muscarinic receptors. Furthermore, if we want to increase ventricular contractility, it's the beta 1s. If we want to reduce atria kick, we want to stimulate M3 cholinergic receptors. In the arteries in the peripheral system, if we want to constrict arterioles, we want to stimulate alpha 1 adrenergics. If we want to vasodilate, there are the beta 2s, just like we talked about just in that previous slide. The vascular tone is then regulated by the sympathetic side only, and that there are no vascular parasympathetic receptors. So I may have, don't be confused, I may have said something about parasympathetic balance in the previous slide, but it's primarily the sympathetic that is responsible for the vascular tone. The local vascular control at the tissue level occurs due to changes on the partial pressures of hydrogen, partial pressures of carbon dioxide, the partial pressures of O2. When cells sense acidosis, so that there are low partial pressures of H or hydrogens, and that there are high partial pressures of CO2, or there's hypoxia, low partial pressures of O2, then vasodilation needs to occur. Okay, let's look at a case study. Let's look at this as it applies from the context of when epinephrine is combined with lidocaine, for example. So this is a dental case study. So let's think, what do we want to happen? Excuse me. Why do we want to make sure that lidocaine action is limited locally? That we only want lidocaine to have its anesthetic effect locally versus systemically. So it's implied that there's a need to vasoconstrict to control the systemic release of the drug. So the question is, can epinephrine cause vasoconstriction? Of course, we know that that is the case, especially we want it to impact locally. What tissues are we in? Well, we know for sure that it's not in the big three. We know that it's not going to be in the brain, heart, or lung, or skeletal muscle. So it's just locally. Thus, epinephrine will interact with alpha-1 receptors and cause vasoconstriction, keeping local lidocaine to that surgical site. Here are the study questions that will keep this section that we just finished in the right frame. So if you can understand these study questions, you are on your way to understanding what we have now just gone over. So let's look at how the autonomic nervous system impacts heart mechanics. We talked about the end diastolic volume, the end systolic volume, as well as stroke volume and its relationship in the part 1 lecture. So let's just recapitulate what we know. We know that the end diastolic volume, so this is the maximum volume minus the end systolic volume, or the residual, equals the stroke volume. And in relation to that, the ejection fraction is equal to the stroke volume divided by the end diastolic volume. So we know that anything less than 55%, the ejection volume, can be pathological and can lead to certain heart conditions. Now, the cardiac output equals the heart rate multiplied by the stroke volume. So if we know the stroke volume from the previous formula, if we multiply that by the heart rate, we know that this is the cardiac output. So this represents the amount of blood pumped in liters per minute. So if we look at an example, if you have 72 beats per minute times 0.07 liters per beat, this on average is going to be 5 liters per minute. This happens to be the total volume of blood in the body. So it takes about 1 minute to move the entire blood volume around the cardiovascular circuit. So very interesting. So what can change? What are factors that can change cardiac output? Well, we already know that obviously the relationship of heart rate and stroke volume is to cardiac output. But let's think of it in some physical conditions. So for example, if you have blood loss or if there's exercise. And with blood loss, you can imagine that your body is going to try to fight its way to making sure that you don't lose more blood. So one way that it's going to make sure that you don't lose more blood is that it's going to decrease stroke volume. Stroke volume is going to decrease. And what's the compensation for that? If stroke volume is going to decrease, the automatic response is to increase heart rate. So what happens in exercise? Well, we know that there's a demand increase, so both stroke volume is going to increase and heart rate is going to increase to deliver more blood to tissues. So kind of understand this relationship of what happens during times of blood loss or during times of exercise. In the case of exercise, we know that cardiac output can increase by more than 5 to 7 times, meaning that cardiac output could be 20 to 35 liters per minute. We know that the autonomic nervous system can alter cardiac output by affecting heart rate and stroke volume, as already discussed. Now let's look at it from a autonomic nervous system stimulation or control perspective. We know that it can increase contractility, which means more blood to be pumped. We know that we can also change the end diastolic volume, which is also termed preload, which we'll look at the definition in the next slide. This is also related to the stretching of the ventricles, for example. So the more we stretch the ventricles, the more contraction. And this is obviously to a certain extent. And we'll look at that with respect to the Frank-Starling law in the next slide. And we can also look at afterload. So what is afterload? It's a variety of mechanisms in larger arteries that can reduce compliance, such as pressure in arteries works against the heart pump. So for example, vasoconstriction. So afterload is, again, to be a little bit more clear, it's just the innate characteristic of arteries that arteries have to create pressure against the heart, because we know that the heart's pumping, but we also have these arteries that create its own natural pressure to create vasoconstriction, for example. So all the factors impact measure of ejection fraction as well. So the end diastolic volume influence on stroke volume, as we mentioned, we've introduced preload. So what is preload? Let's get into it a little bit more. So preload, we can equate it to greater filling if there is more stretch in the ventricles, and this could lead to greater contraction. However, there are limitations, and we call this the Frank-Starling mechanism. So it occurs in the absence of any neuronal or hormonal input. It is, again, virtue just related to the mechanics of the stretchiness of the ventricles. So the stretch causes muscle fibers to contract more efficiently. The heart moves along the curve to match the venous return. So here's that relationship of ventricular and diastolic volume. We know that there is this normal resting volume of the ventricles, and the normal ventricle is associated with a stroke volume, which is about 70 milliliters. However, we know that during times of exercise, for example, we can increase this ventricular and diastolic volume. And in turn, there's this also increase in venous return, as you can imagine, which is associated with an increase in stroke volume equal to slightly over 100 milliliters of a stroke volume. Let's take this the next step forward and look at how the stretchiness of that muscle fiber itself. Let's look at the sarcomere, the relationship of the sarcomere length versus the tension generated upon stimulation. So the length-tension relationship is going to be studied here. And we know that, that during rest, we don't need to contract the ventricles that much. We don't need to contract the sarcomeres that much. They're not overly contracted. But there is this optimum resting length, as you can see, between 2 to 2.5 micrometers, that the sarcomere is optimized in this inverted U shape so as to optimize the length of the sarcomere versus generating the greatest amount of tension. So this inverted U-shaped curve demonstrates the length-tension relationship with an optimum length of the sarcomere. You wouldn't want your heart muscles to be overly contracted at rest, nor overly stretched in a decompensated period. So, as the heart fills with more blood than usual, the force of cardiac muscular contraction increases. This is a result of increase in the load experienced by each muscle fiber due to extra blood load entering the heart. The stretching of the muscle fiber augments cardiac muscle contraction by increasing calcium sensitivity of the myofibers, causing a greater number of actin-myosin cross bridges to form within the muscle fibers. Let's look at afterload. So afterload. a variety of mechanisms in larger arteries that reduce compliance. For example, pressure in the arteries work against the heart pump and can cause vasoconstriction. The high pressure in the systemic circulation makes it harder for the heart to deliver blood. So this may be due to the vasoconstriction as well as the decreased compliance of blood vessels. Again, we want to underscore that in the peripheral vasculature, there is an innate force that goes against the pumping of the heart. We don't want the heart to be overly pumping. We want a little bit of pressure on the heart so as to not pump so much if needed. Obviously, there's a lot of other factors here. This also reduces stroke volume, and this is important in the significance of hypertension and heart failure, and not as much in normal physiology or younger people. Excuse me. So if we look at our model again during systole, the ejection of blood into the arteries from the heart, the arteries show the bulging of the arteries, and we know that there's a certain amount of force that the arteries that they can take. So we kind of term this compliance. How compliant are your arteries? Well, if they're normally compliant, they only stretch out this much, so that during the rest or the relaxation of the heart during diastole, the compliance of the arteries will make the arteries kind of in this normal position, and again helps to control the blood pressure in the periphery. And we'll talk about mean arterial blood pressure in a minute. So here's just a nice summary of what happens during an increase in end diastolic ventricular volume, as well as an increase in sympathetic nerve activity, which through an increase in plasma epinephrine can increase stroke volume, as well as if there's a decrease, if you remember, we talked about we can decrease parasympathetic activity to stimulate the SA node and increase heart rate, which obviously has this great impact on cardiac output. For study questions, if you can understand what's happening again with the factors that influence stroke volume, with how the Frank-Startling mechanism is an innate mechanism of the intrinsic characteristics of the heart and the ventricles specifically, what normal cardiac output is, the factors that control cardiac output, knowing and understanding how the sympathetic nervous system can impact the Frank-Startling curve. Why is it important for us to have arterial compliance? We need that force that opposes the heart pumping is very important, okay? And we know that we can't have rigid tubes, but we also can't have a tube that's also too lax as well. Let's look into arterioles and capillaries a little bit more. If you put them all together, they account for 25 miles, 25,000 miles. Check that, 25,000 miles. If you were to kind of connect all these pathways and system of vessels together. And at any given time, they account for holding the volume of about 5% of blood. The cells of tissues that need to exchange nutrients and materials from capillaries must be less than 0.1 millimeter away. And the flow or the velocity decreases quite a bit as the blood moves from the heart to the major arteries to arterioles into capillaries. The flow starts to decrease quite a bit, especially at the capillary level, where the main area of exchange occurs. It has to be slower. You know, it makes sense, right? When you're going to get dropped off, when you get dropped off by a bus, train, or a car, even a plane for that matter, it has to slow down for there to be an exchange. And the model on the right here just shows you, again, just kind of to recapitulate what we talked about in part 1. This is pulmonary circulation. Here is the systemic circulation, and here is where the heart circulation occurs. Okay, let's dissect the capillary a little bit further. Why? Because again, we know that this is where the exchange of materials to provide nutrients to the cells mainly occurs. So all blood vessels are lined with a thin layer of endothelium, a type of epithelium which is supported by a basement membrane. Here's the basement membrane here. Here is an endothelial cell. Okay, there are multiple different kinds of endothelial cells. That's why you see cells 1 and 2. Okay, and there's an epithelial that supports the basement membrane called the tunica intima. Capillaries are approximately 1 cell thick on the basement membrane. Okay, there are no smooth muscles, so there's no contraction of blood vessels here. There is a system of a way that at the level of the capillaries that blood can still be controlled, but technically there are no smooth muscles here. Again, the diameter allows 1 cell at a time to squeeze through. So you can see here, we see a erythrocyte that is about the size of a capillary. And we have what we call fused vesicle channels. Here is a fused vesicle channel. Here is a intracellular cleft. And other pores that are sometimes we call fenestries that make the capillaries leaky. Right? We want the exchange of material between, for example, oxygenated blood versus deoxygenated blood. And this table here of figures of arteries, arterioles, capillary, venule, and finally veins, kind of in that order, would be how blood would flow through. It just gives you kind of a comparative analysis of their diameter, their wall thickness, their makeup as far as endothelium, elastic tissue, smooth muscle, and fibrous tissue. So let's look at the capillary bed a little bit further and see how the arterial system versus the venule system interact with one another to obviously bring nutrients to the level of specific organs. And as we mentioned earlier, that at the level of the capillary, there are no muscles. There are no muscles at the level of the capillaries. However, there are these what we call pre-capillary sphincters, these things that kind of go around the capillaries here, these things that kind of wrap around, looks like a vine almost. Okay, these can contract and relax to regulate blood flow. You can see here this system at the capillary where we can see intercellular clefts as well as endothelial cells that again kind of line the capillary system. So we know that diffusion is obviously not only a main activity at the capillary level, we know that is a driving force to exchange most substances. As we know from physics, most substances move from areas of high concentration to low concentration, both transcellularly, through the cell, and paracellularly around the cell via the pores and fenestries that we mentioned in the previous slide. Okay. Now we know that polar molecules can go through clefts and channels in the endothelium. So what natural question you would ask regarding glucose transport? What transporter is necessary for glucose transport in the skeletal muscle? As we know, there are glucose transport channels, if you will. And as far as nonpolar or small molecules, they can simply diffuse right through the endothelial cells, especially oxygen and carbon dioxide. So, what is the driving force of diffusion? It depends in terms of what substance, whether it's polar or nonpolar. That helps to determine if it has obviously a transporter that can help to regulate the substance, or if it's nonpolar, as we mentioned, it can diffuse right through. We will talk in the next couple of slides about bulk flow, partial pressure differences, osmotic and hydrostatic pressure in the capillaries versus the interstitial fluid to again help regulate the substances to bring about homeostasis. So what is the capillary exchange by bulk flow? We know that solutes can move by bulk flow, which refers to the mass of movement of solvent across the capillary wall. Bulk flow occurs via paracellular, again meaning kind of around the cell via pores and fenestries. So let's think about the capillaries for just a moment. And if you remember physics and you talked about pressure, most likely you talked about hydrostatic pressure and osmotic pressure. So we can think of hydrostatic pressure as blood pressure, and we can think of osmotic pressure as pressure exerted by solutes within the plasma. So for example, we know that high levels of solute favors the movement of water into the capillaries. And here's an example of determining the arterial pressures at the end of the arteries as well as the end of the venous pressure. So the net pressure is equal to this hydrostatic pressure minus this osmotic pressure. So these are the two pressures that you want to account for as the main driving force of bulk flow. In the artery end, the net pressure, as you can see, 33 millimeters of mercury minus 25 millimeters of mercury equals 7 millimeters of mercury, which favors filtration. So at the arterial level, the flow is out of the capillary, which makes sense, right? Nutrients are primarily going into organ cells. Whereas at the level of the veins at the end, if you have 15 millimeters of mercury as the hydrostatic pressure minus the 25 millimeters of mercury as an osmotic pressure, there is this negative 10 millimeter of mercury product, which favors absorption. So the flow now is into the capillary. There is another factor to consider within the context of total net pressure. So we've accounted for capillary pressures, such as this hydrostatic as well as the osmotic pressure. But we do have to consider the impact of interstitial fluid. So the fluid that is outside of the capillaries. And we know that proteins can provide a significant contribution of osmotic pressure. However, in the interstitial fluid, there are very few proteins. So the effect of osmotic pressure in the interstitial fluid is usually 0 or very small. And so therefore, you're just left with the hydrostatic pressure of the basically water fluids that is in the interstitial fluid. We know that bulk flow is important for solutes such as sodium and potassium, calcium, and many other important minerals. What happens in edema? So as we know, edema is just kind of a general swelling, usually as it relates to venous or interstitial fluid compartments. Many things can cause edema. It's both genetic and behavioral. It can be caused by infection as well as other diseases such as diabetes. So edema is usually a symptom of something else that is causing this edematous occurrence within the body that is causing some kind of swelling. Most notably, extremities become edemic. However, there are other areas that edema can occur in the brain, for example. Even in the eye, there could be edema that can occur. So here's what the last couple of slides, when we talk about the pressures, bulk flow has an impact of fluid movement, material and substance movement. You can see as blood enters the capillary, so from arteriole, so a small artery, for example, we know that the blood pressure here is greater than the osmotic pressure. So that tells you that you can see how the net pressure is a little bit bigger of fluids to leave the capillary system. Okay. Conversely, as the blood leaves the capillary to the venules, into, for example, a small vein, we know that the osmotic pressure is now much greater than the hydrostatic pressure or blood pressure. Hence, the movement of the net pressure movement wants fluid to go back into the venules. Okay, so what happens outside? Well, as here we see cells, the organ cells that are getting the benefits of this transaction of this of substances, nutrients coming into their cells here from the fluid here. The fluid does have to return. It returns back, as we just mentioned. However, there is some fluid that will be collected within the lymphatic system. So the lymphatic system, that being another system that would help to not only as part of your cardiovascular system, but many times it is associated with your immunological systems, as it gets rid of toxins and byproducts of toxic substances in the lymph tissue. So the pressure drops as the blood progresses through the capillary, as we've mentioned. However, the net inward pressure at the venule end does not quite balance out the outward pressure at the arterial end, and hence, therefore, you have this fluid that becomes lymph fluid. Now, it's worth mentioning the arterial system that goes to the brain is obviously very important. That goes without saying. We need blood flow to the brain for sufficient brain neuronal functioning. However, the arterial system that goes to the brain, it's a little bit more complicated. It's complicated in a sense that, as you can imagine, where our brain has to be finely tuned and can have no margin of error as far as dysregulation or unregulation of homeostatic events. We need to have a system. We need to have a process where the blood-brain barrier is able to let things in that it needs, but make sure that it protects itself by not letting things in. So in the brain, we have what's called the blood-brain barrier. And unlike arterioles, where there are intercellular clefts and fenestrated pores that more easily allows flow of nutrients, there are now tight junctions in the blood-brain barrier. So this is akin. It's almost like the Berlin Wall. So if you remember, in Germany, when the Berlin was separated to West and East Berlin by the Berlin Wall, the wall did not allow any East Germans, for example, to cross into West Germany. So this is similar. This is the analogy that the gates, if you will, of the brain is strictly controlled by the blood-brain barrier. And so substances must be transported across the blood-brain barrier, endothelial cells, for entry into the brain. It's always like a guard that has to bring you in. Surrounding cells that perform metabolic functions, so such as parasites, can act as a secondary defense, and you can see all the other defensive mechanisms within the brain. For example, there are microglia cells, astrocytes within the brain itself, and obviously in the blood circulation there are lymphocytes, monocytes, and neutrophils if needed. And we know that many drugs cannot pass through, and one of the most important criteria as far as drug characteristics that allows a substance to go through the blood-brain barrier is that it must be lipophilic. Must be lipophilic. Let's also now talk just a little bit about the physical sciences of hemodynamics and pressure. So we know that a pulse or a cardiac cycle creates and maintains pressure. The interaction of pressure, so sometimes denoted as P, flow rate, denoted as F, and resistance, denoted as R, is referred to hemodynamics. So flow rate is proportional to the pressure difference between 2 points, so that's the delta P, over the resistance. How do we measure pressure? There's going to be various metrics as far as measuring pressure. One is the pulse pressure. So this pulse pressure is simply the difference between systolic pressure minus diastolic pressure. And pulse pressure can be influenced by stroke volume, the velocity of that stroke volume, ejection, as well as compliance. So we mentioned, again, the importance of the two forces, the force of the heart and the force of the arteries, and that force, we can simply call it compliance, that allows this homeostatic event where the power of the heart cannot be so much as to pump too much because it's overcome by the compliance force of the arteries. The pulse pressure varies throughout the cardiovascular system, and it decreases as the blood distances its way from the heart. So that's what you see here in this bottom figure, where is in systematic circulation from the arteries to the arterioles to the capillaries to the venules, there is this decreasing pulse pressure. Okay, and going back to the arterial pressure itself and how do we measure pulse pressure, here we're looking at the diastolic pressure at usually on average 80 and systolic at 120. So this pressure difference is what we call the pulse pressure, and that there is a mean pressure that we'll talk about more in a second that we call mean arterial pressure. Okay, so what is mean arterial pressure? Is the average arterial pressure over the entire cardiac cycle. So here's again the dashed line. Unlike pulse pressure, the mean arterial pressure is the same throughout the body. Okay, we have and then the mean arterial pressure typically increases with age, often reflecting the effects of atherosclerosis and reduced compliance of the arteries. So here's as we age, the mean arterial pressure increases. There is this leveling off period after the age of 40 years old. What are the factors that determine flow rate? Okay, we already mentioned the equation for flow rate. Flow rate is equal to the change in the pressures divided by the resistance in milliliters per minute. A change in pressure is the flow rate. So here's an example, a question that we're trying to decipher is the flow rate different between these two scenarios. So at one pressure point, P1, in that first bullet, it's 100 millimeters of mercury, and at point 2, it's 10 millimeters of mercury. So 100 equals, 100 minus 10, which would equal to 90 millimeters of mercury. So is that different? Is the change in pressure different from that one to the one below? 750 minus 690, and the product, or the difference between those two is also 90. So there is no change in pressure, as well as if all else being equal, meaning if the resistance was the same, the flow rate in this example would be the same. Now resistance. Let's look at the resistance. And it's related. There's an inverse relationship with the vessel radius. That's why we have that there as an exclamation point. So as the radius of the vessel narrows, there is more friction within the walls. Okay, so you can, again, this friction can cause some pathophysiology, like, for example, aneurysms. An aneurysm is where an artery can bulge. Before that, it can become damaged as a result of high blood pressure, as a result of atherosclerosis. It can be damaged, and over time, it can start to lose its compliance, and it can bulge, and finally it can rupture, and that's what an aneurysm is. Since the relationship between the blood vessel radius and flow rate is exponential, a very small change in the radius has a large effect on blood flow. So you could see the relationship of the resistance is equal to 1 over the radius raised to the 4th power. Okay. Interestingly, in aorta, other large arteries uniformly have little resistance to flow, even in spite of moderate changes in compliance. Arterioles are definitely important. Okay, so how would increased viscosity impact flow? So you can think of viscosity of the difference between something that has low viscosity, such as water, versus syrup that has high viscosity. And yeah, when you pour water, it flows pretty good, right? When you have pancakes and you eat it with maple syrup, the flow is a little bit less, and so it has high viscosity. So you can think of having higher viscosity, meaning that there's more red blood cells. And so how does the cardiovascular system compensate for high viscosity? You can imagine that as your blood becomes more viscous, now the heart has to work that much harder. So every time the work is increased, and even if it's by a fraction, you can imagine over time that repeated force and resistance that's on the walls of the arteries can degrade the arterial walls, and it can cause the reduction in compliance. And it can ultimately lead to, for example, not only atherosclerosis, but eventually, potentially, aneurysms. Let's recapitulate what we know about arterioles and blood pressure and flow. So we know that arterioles are the smallest arteries. They can be controlled by a variety of factors: neuronal, hormonal, and local chemicals. Gateways for blood flow into associated capillary beds of specific tissue organs. So they are kind of the last road that leads to the organ of interest. Contraction diverts blood flow away from the organ, and dilation allows blood flow to the organ. Arterioles leading into the capillary beds are usually just a single layer of smooth muscle around endothelial cells lining the arteriole. Arterioles as a group are the major factor in determining mean arterial pressure. And we know that this mean arterial pressure is under homeostatic control. Mean arterial pressure is dependent on two factors, mainly cardiac output and total peripheral resistance. So cardiac output, as we've already discussed, is equal to the product of heart rate times stroke volume. It represents the amount of blood pumped in liters per minute. The total peripheral resistance is the total resistance to flow in systematic blood vessels from the beginning of the aorta to the end of the vena cava. So the sum total of all of the constricted arterioles. So together, the mean arterial pressure is the cardiac output times total peripheral resistance. This is just telling us that the diagram shows us that mean arterial pressure is unchanged with any arterial compensation, especially as if you think of the mean arterial pressure, or the arteries are unchanged. But if you look at, so here, when you compare these two scenarios, we have the same mean arterial pressure. And if you look at, we also will have the same amount of cardiac output into both reservoirs. The total peripheral resistance, as you can see, that the two instances where there is no issues with flow, meaning that the artery here is completely straight and there are no narrowing, unlike these three that you see here. Okay, and if these are just randomly switched around, as it is in this example too, that the flow to the organs in total will still equal one another, that this scenario A and this scenario B are going to be the same. So the radii of arterioles, they can be altered, as we've demonstrated here, which influences resistance and ultimately blood delivery to an organ. So they obviously the organ flow will be a little bit different in those where there is a narrowed resistance. As far as arterioles, they are, as a group, are a major factor in determining mean arterial pressure, as we've denoted already. Arterioles in individual organs are responsible for determining the relative blood flow to those organs at any specific mean arterial pressure. Arterioles are regulated by both a local or an intrinsic control that's related to paracrine and autocrine interaction. And then there's this intrinsic control. So extrinsic, meaning cells distant to the organ, can control arterial resistance. So for example, the sympathetic nervous system. We know that blood is obviously distributed based on metabolic need. Differences are due to the interplay of vasodilation and vasoconstriction in arterioles supplying the organ. Let's take exercise, for example. It obviously increases overall cardiac output, but not equally distributed to all organ systems, right? We know that skeletal muscle, as we have strenuous exercise, it's probably going to have the greatest change. Whereas in the blood, it doesn't change a whole lot. And in the heart, there is an increase, but not by much either. Skin, skin's probably the other area where there's going to be a next greatest increase in blood flow. Okay, kidneys about the same. The abdomens will decrease. That your GI area will have a lower blood flow. So you can see quite a bit of a difference as far as flow at rest at 5,000 and flow during exercise at 17,500. So an unequal distribution is a result of both local, we've mentioned some local controls, especially with respect to paracrine and autocrine hormonal activity, and or distant regulators, including neurotransmitters or hormones related to the sympathetic nervous system. Okay, let's look a little bit deeper about local controls. What are local controls that impact blood flow? We have two kinds. So we have active hyperemia as well as flow autoregulation. So as you can see here, hyperemia, increase blood flow. This is active if due to metabolic activity, if there is a certain increased activity. For example, your brain needs oxygen as a result of wakefulness due to studying or even exercise. We know that this process of that organ's going to need it. There's a decrease in O2, so it's going to increase its metabolites in the organ interstitial fluid. It's going to the arterial dilation in the organ is going to happen, and therefore you're going to have an increase in blood flow to the organ. Okay. Flow autoregulation, it's again kind of related to this, something intrinsic within that area, that local area. Sometimes it begins with a sense of decrease of arterial pressure in the organ, and that mechanism of low arterial pressure will get blood flow to the organ going, and as a result of oxygen and other metabolites and a decrease in vessel wall stretch, this is going to dilate arteries and therefore restore blood flow towards normal levels. So definitely another hemostatic control that exerts kind of that have the end result of improving or restoring blood flow, but just by kind of two different mechanisms. Again, this is all to have a fail-safe mechanism of keeping us alive. Other local controls, we mentioned the paracrine is when a cell can secrete something to its adjacent neighbor, for example, and to induce either relaxation or contraction. One of the most important substances is nitric oxide. So nitric oxide is definitely a drug target by many pharmaceuticals to, again, to control the relaxation or contraction of smooth muscles, whether it's in the lungs, whether it's in the heart, blood vessels, and sometimes, obviously, combating conditions such as asthma, blood pressure, as well as even in lifestyle changes. As we know, Viagra works on this system of nitric oxide to relax smooth muscles, thereby Viagra doing its thing. Nitric oxide constitutively secreted by endothelial cells causes vasodilation and is critical to proper vessel tone. It can also be stimulated by other processes such as inflammatory assaults. Okay, so let's look at, again, a higher level overview of the differences between the controlling of arterial resistance. So one, we've just already talked about the local controls that calls for the cells of an organ to control their own arterial resistance via autocrine or paracrine. And the example that we just talked about is nitric oxide. So this is obviously very important as the organ kind of controls itself. The other two regulatory mechanisms alluded to was active hyperemia and autoflow regulation. As far as intrinsic controls, so what is it that can impact the arterioles from a distance? Okay, so the response can serve the whole body. For example, overall blood pressure. And so one way to control overall blood pressure through the autonomic nervous system are through baroreceptors and chemoreceptors, excuse me, as well as other hormones. So in the next couple of slides, we'll look at the baroreceptor response. But do understand that it's blood pressure is an integrated regulatory process that constitutes both these local controls as well as these extrinsic controls. So baroreceptors are afferent neurons that respond to pressure via stretching of arterial walls. So the two more common places where these nerve endings are located so that they can detect pressure differences is the carotid sinus and the aortic arch. Therefore, the baroreceptor nerve an action potential can increase in response to increases in any change in meaning up or down of mean arterial pressure, as well as pulse pressure. So if there's a greater, what this means is if there are differences in the pulse pressure, it becomes more sensitive. Sensitive meaning the baroreceptors become more prominent. The greater the difference in the pulse pressure, remember that the pulse pressure is a difference between systolic blood pressure and diastolic blood pressure. So anything that will dysregulate that homeostasis the baroreceptors can detect. Okay, so here is a nice video of how the baroreceptor reflex control of blood pressure works. I'm not going to show it here because it doesn't work very well with this video capture that I'm using. But I'm going to go through a step-by-step process in 2 or 3 slides. So let's look at how the baroreceptors achieve homeostasis by its interaction with the medulla. So if you remember the medulla in particular, in this case, as far as regulating cardiovascular events such as increased mean arterial pressure, is through the cardioregulatory and vasomotor centers. They receive the signal right here. And this is the green line signifying that there is a sensory afferent neuron that fires action potentials that tells the medulla that, hey, there's an increase in mean arterial pressure. Please activate the parasympathetic system to increase vagal output to decrease the heart rate. So this red right here should be designated parasympathetic nerve, while in cases where the mean arterial pressure needs to increase, there would be a decrease in parasympathetic tone, and there would be an increase in sympathetic tone, i.e. epinephrine, norepinephrine. And so this system right here, the sympathetic nerves, would go ahead and release norepinephrine at the SA node, right, as well as some myocardium of the atria and ventricle to conduct a higher heart rate. Also, as the sympathetic nervous system, it does have an impact on blood vessels. And the impact is that during a sympathetic innervation activity, there would be a vasodilation of these blood vessels. If there's a long-term high blood pressure chronic condition, the baroreceptors will adjust the set point to a new higher level, and there will be no longer a lower level. So this is kind of leads to this hypertensive cycle that can lead to obviously chronic hypertension and can be very serious if this whole process, if the blood pressure is not controlled. One thing to point out is, again, we can see how some pharmacological influences can impact the contractility of the heart by slowing the heart down, again through alpha adrenergic stimulation, beta adrenergic stimulation of those receptors of the heart. I like this figure much better as far as kind of giving us the big picture of how the baroreceptor reflex looks like. So in this example of blood loss or a hemorrhage, there will be an immediate decrease in arterial pressure. And again, the firing by those atrial baroreceptors, that sensory afferent nerve will create an action potential to stimulate a decrease in parasympathetic discharge, an increase in sympathetic discharge. So here we would be lessening the vagal stimulation, whereas here we are increasing the discharge of, for example, norepinephrine epinephrine at the SA node level. Remember that the epinephrine, norepinephrine, and the sympathetic can also influence the cardiac muscle itself. It can make the myocardium of the ventricles contract that much more forcefully. So realize that there are two mechanisms by which this increase in sympathetic discharge impacts and increases cardiac output. You can look at for yourself its impact on the venal and arterial system. Okay, an increase in sympathetic discharge would increase constriction. An increase in sympathetic discharge would again increase constriction, as we learned earlier in the slide with the innervation of alpha-1 adrenergic receptors at the arteries. This increases total peripheral resistance to achieve our goal of normal arterial pressure. This is just showing you the chemoreceptors and the medullary inspiratory centers controlling breathing and its impact on the heart. Again, a very important place, the medulla oblongata, where there are receptor cells near the respiratory center that responds to changes in cerebral spinal fluid H pluses caused by an increase in arterial CO2. The receptor cells at the level of the carotid and aortic bodies respond to these large decreases in aorta. Okay. This sends a negative feedback loop. Okay, so much like the baroreceptor reflex, the baroreceptor reflex is also a negative feedback mechanism. And through this, the higher centers in the cortex can exert some conscious control of respiration. So we can, as I talk and get over my cold, as you hear me kind of wheezing and breathing a little bit heavily because of my cold, I'm trying to get more oxygen to my lungs and brain, and I do that conscientiously by activating my diaphragm, for example. All right, so this is just again showing you more of the negative feedback loop. That is the afferent baroreceptor neurons that can fire action potential, that can either activate the parasympathetic vagal tone to decrease heart rate, or to increase sympathetic tone to increase heart rate. And you can see the two purposes of sympathetic innervation, which is not only the heart, but at the level of artery and venal constriction. So let's look at the medulla, specifically the cardioregulatory and vasomotor centers response to the pressures of oxygen, carbon dioxide, and hydrogen. So, excuse me. So what happens when there's a decrease in the oxygen, as well as hydrogen, and an increase in carbon dioxide? So really the main outcomes is that the parasympathetic will be activated, that vagal nerve, that vagal tone would be enhanced to either decrease heart rate, or the sympathetic nervous system is innervated to increase heart rate. So which one do you think dominates in this particular case? Well, we know that it's probably going to be the sympathetic nervous system, as it figures out a way to increase the lack of oxygen as well as H pluses to remove the carbon dioxide in the system. So that's in a nutshell what is happening with the pressures of these important gases. Here are the study questions. So you should be able to, as you read them, go over them, you should be able to answer them. And I think we've gone over the answers to a majority of these, if not all of them. So lastly, let's look at the lymphatic system as it relates to the cardiovascular system. Again, the lymph system is a very important thorough way for many things related to fluids that are of immunological value. A lot of waste gets recycled within the lymph nodes. A lot of our immunological substances reside in the lymphatic vessels. So it's a very important thorough way and storage place for mainly immunological responses, but also cardiovascular, as we will look at to them now. Just a little bit of anatomy and physiology. We know that as far as the places where lymph is transported, so the thoracic duct is a transport system for lymph through the thorax from the left side and lower extremities. You can see where it empties at the junction of the left subclavian and the left jugular. The right lymphatic duct drains in the right side of the thorax, right arm, and the right side of the head, empties at the right junction of the subclavian and the jugular vein. The lymphatic vessels have valves to also prevent backflow. That makes sense. Well, one condition when there is a accumulation of lymphatic fluid primarily in the lymphatic vessels, and usually there is due to there is a blockage. It's usually one mechanism is via mosquito-borne worms. Let's look at the venal system. So this serves as a reservoir containing 60% of the blood at rest. So you can see at the picture here, the model, that the area of the veins seem to be much greater than the areas of the arteries. As we know, it's relatively in low pressure. The constriction is under sympathetic nervous system control, which can increase venous return. The driving force is that arterial pressure, as we've kind of talked about, the arteries, as well as the heart. Obviously, the heart serving as the main pump. The arteries and its arterial wall have force. The compliance of the arteries have a force component to it to impact the force driven through the vein, the circulatory in the veins. So what impact will this have on end diastolic volume and preload? So you definitely have to have some pressure, and the average pressure at 5 to 10 millimeters of mercury will fill the heart at its normal fill. However, anything that would dysregulate the integrity of this system can change the volume, that end diastolic volume, and hence can impact the preload volume of the heart and therefore impact stroke volume and eventually cardiac output as well. We know that venous flow is assisted by skeletal muscle pump mechanism working in combination with one-way valves. There's a similar mechanism that exists for the abdomen and thoracic cavities driven by diaphragm movement. So you can see that the blood flows only toward the heart in the venal system. So while standing, the force of gravity causes a large amount of hydrostatic pressure, thereby pulling blood in the leg veins primarily. Contraction of the leg muscles clears out the accumulated blood. And so what happens when you put your leg up? You take a load off. What do you think happens there? As we know, that helps to sometimes improve the circulation throughout the entire body. Notice that the pressure due to gravity is approximately 80 millimeters of mercury, and the pressure due to gravity is approximately 14 millimeters of mercury. So remember that everything is connected. The Frank-Starling mechanism, as we talked about, really is a mechanical mechanism, and that the physics behind the pressure associated with blood flow impacts the Frank-Starling mechanism primarily, so that greater filling occurs when there is more stretch to the ventricles. And then, of course, there's going to be a greater contraction needed to eject that amount of blood. And this graph here, as we've seen before, just shows that the normal resting value of ventricular and diastolic volume versus what happens when there is an increase in venous return. That would impact an increase in stroke volume, thereby making your heart work a little bit harder. And in chronic conditions, we don't want this. Obviously in acute conditions where during exercise and during work, that's okay. But at the same time, we don't want our heart to work too hard. Here are the last of the study questions. So by now, this has been, I hope, a very useful and information overview of cardiovascular system from the heart to the peripheral vasculature. Hopefully this will aid in your study of the pathophysiology of the cardiovascular system, the pharmacology of the cardiovascular system, and to aid overall in the overall health and wellness of your patients. Thank you very much.